My pre and post procedural deep and fundamental concept. This is very important. My lecture will give the message to the to at least good before becoming an interventional cardiologist. This is my message. All modalities. Among them, ECO is one of the best tools to perform the good intervention, prerequisite of good interventionalist. Before presentation, because today is the 16th December, Victory Day, I like to my heartfelt gratitude and respect to the Bangabandhu Sheikh Mujibur Rahman, who is the father of nation, and for whom we got the independence of Bangladesh. The echocardiography to assist. Not with echocardiography, we will not intervene because day long we learn things from the legend cardiologist and echocardiographer. So I did not repeat these things, but it is one advantage is that it is mobile and real time, and also it is very important tools for heart care management. For particularly care who need to implant CRT, who fail the OMT and GDMT, those heart failure patients who got the repeated rehospitalization, repeated decompensation of the heart failure, who needs and who fulfill the criteria of the CRT needs to very good evaluation of the of this patient by echocardiography, because it is completely harmless and riskless. So echocardiography techniques are potentially aids in patient with selection of CRT and optimal after. What are the we can use to select the optimize pre and after? Is the in non-invasive and interventional cardiology. Keeping the interventional cardiologist, it is a clinical, already we said, and then become the interventional cardiologist, which is the apex of pyramid. And if you the cardiologist role, so role of and patient selection and evaluation is very important. My domain discussed by Sabina Hashem nicely. End stage heart failure already discussed, and recommendation of echo evaluation before and after CRT. Management of heart failure we know, but see the end stage heart failure stage D has 30 to 78% mortality per year, and also said repeated rehospitalization and decompensation, and quality of life is very hell. So we know we must know the class 1 recommendation LVF 30 less than 35% and QRS more than 150 millisecond, sinus rhythm with LVB. This is class 1 recommendation, and this is also other special recommendation is there. Echo evaluation of the heart, very important tools already been discussed in heart failure, but among them the EF is very important because it is the 35% of EF for CRT-D implantation. So the modified Simpson rule in apical 4-chamber and apical 2-chamber view at the end diastole and end systole, excluding the papillary muscle, should be excluded from the cavity in the tracing. So clinical benefit of resynchronization therapy, because in the dilated heart it is desynchronized. What The several randomized trials that use all-cause mortality. Echo in CRT perspective. But there is a study, the echocardiography and cardiac resynchronous therapy is whether they are friends or foe. Because some studies goes against the echocardiographic role to implant on evaluation of CRT device. So what the 2D to select the which group are responder and non-responder, and atrioventricular delay and lead position is also important and role by echocardiography. What there are three types. One is mechanical descent, one of the in heart failure and ICM, DCM patient, both having the electrical as well as mechanical, that is optimal CRT response, and electrical descent, that is less favorable for CRT. Support that the electrical descent is the best associated with the optical CRT. So atrioventricular said, and there is the M-mode showed the septal to posterior wall delay. 150 seconds we can detect septum to posterior wall delay by echo left ventricular ejection interval by AV valve closure and opening. And there is the descent detected by TDI. There is the two peak septum to lateral wall, and descent detected by TDI and also delay, and also 140 millisecond between the septum and posterior also can be depicted. It is normal in 65. And lateral wall and as compared to the septum is also can be detected by pulse Doppler. And interventricular mechanical delay also can be detected by echocardiography by will be a right ventricular outflow tract and left ventricular outflow tract. And TD longitudinal strain and strain rate and displacement is also we can show that there is the normal synchrony, there is desynchrony, there is RB and LB peak is depressed. 2 minutes. There is three-dimensional also definite role, and post-CRT is very important. AV optimization, AB and VV optimization, AB and VV optimization. I think, but this is one the programming the CRT implantation MR is reduced, and and also effect of AB delay also optimized by the echocardiography A and EOF pattern in the mitral flow and optimized by AB delay. And LBOT VTI also we can use to optimize, and mitral inflow VTI also can be optimized, and diastolic MR is also can be optimized, and LV DPD ADT also can be optimized by the echocardiography, and LBOT VTI method already shown. And so my take home message, do not selection of patient with this echo exciting and evolving role in post-CRT implantation rather than patient selection. Although a great deal of work in hope of refining patient selection and guiding the lead placement, echocardiography has a definite role for post-CRT patient to optimize the atrioventricular and reduce the MR, mitral regurgitation. Future to 7 promising studies are ongoing. Thank you.